and that's where we ended. So we are done up to question 40. Which of the following is true about the cochlear duct? It contains endolymph and is separated from the scala vestibuli by a retinal membrane. Contains perilymph and is separated from the scala tympani by the basilar membrane. Contains endolymph and is separated from the scala tympani by the tectorial membrane. It contains perilymph and is separated from the scala vestibuli by the organ of Corti. Anyone that can help with this one? Which statement is true about the cochlear duct? Anyone? Are people in church or what? Why don't you want to speak? Okay, so we know when we are talking about the ear, say there is our outer ear, the pinna, and then we are going to have the external auditory canal. So these two making up the external ear. We are going to have the tympanic membrane here. After the tympanic, so this will now be the beginning of the middle ear. Attached to the tympanic membrane, we are going to have the malleus, which is an ossicle, a bony ossicle. Then attached to the malleus, we have got the incus, which is another bony ossicle. Attached to the incus, we have got the stapes, which is another bony ossicle. And then now this guy, the stapes, is specifically attached to part of the cochlea. You know, a cochlea is this shell-like, snail-like structure, like that. And then we are now going to have at the end there we're going to have the semicircular canals having the lateral, the anterior, and the posterior semicircular canals. So something like this. When you look at, so this is making up the middle ear, the bone ossicles, which are the three of them, and two muscles, the stapedius and the tensor tympan and this membrane here. Now that's middle ear. When we go to the inner ear are found in a bone, part of the temporal bone, the hard part of the temporal bone. That's the petrous part of the temporal bone. And when you look at that petrous part of the temporal bone inside, so we call it the bony labyrinth. Labyrinth is just referring to inner ear. So the bony labyrinth, inside the bony labyrinth, we are going to have the membranous labyrinth. Now, inside the membranous labyrinth, we are going to have these spaces. So that's the membranous labyrinth. And specifically, we have got three many spaces. We have got the what we call the vestibule, which is the central part, the vestibule. Now, the vestibule is also known as the otolith organs. That's the sacule and the utricle. And then you are going to have the three semicircular canals, which is anterior, posterior, and lateral. And then we also have the cochlea. So these are the spaces that we find in the membranous labyrinth. Now it is good to understand how they go. So you can see where this bone, the stapes, is connected. The stapes is connected on part of the cochlea. So this structure is the cochlea, and then on the middle here, that's where we're going to have the vestibule, or not the vestibular apparatus. So the vestibular apparatus is the entire of these structures involved in balance, including the semicircular canals. But the vestibule is just the otolith organs, those that are involved in just noticing. linear acceleration. So when you look at the structure of the vestibule, actually just all these canals, start all these three that we've mentioned here, inside they have got endolymph. Now specifically when you go to this guy, the cochlea, you make a cross section of it, you are going to see three cavities inside the cochlea. The one on top is a scala vestibuli. So scala vestibuli, and then you have got the one down which is a scala tympani, and then this guy here on the middle that is a scala media. The scala vestibuli is going to come and open somewhere here where you find the oval window. The scala tympani is going to continue to where you have got the round window. The round window is somewhere down. This guy and this guy have got perilymph, which is rich in sodium. The scala media has got endolymph. Actually, the scala media, because it has got endolymph, it is continuous with these canals. You can see this, the semicircular canals, the circles, the utricles, and the scala media. They all have endolymph. It's just the scala vestibuli and the scala tympani which have got perilymph. Now, when you just get the cochlea alone to look at the structure so that we can be able to answer this question properly. Let's see how it is organized. So the cochlea, as we said, it has got those three cavities, scala vestibular and scala tympani. And when you look at the way the cochlea is, it goes like this. And at the end where it is so pointed, we call that as the apex. At the apex, the scala vestibular and the scala tympani communicate. You have got what we call the helical streamer there. That's where the two guys communicate. Now, the scala media, which contains endolymph, is also known as the cochlear duct, and it is going to end at the apex, and the apex where the scala media or the cochlear duct ends is known as a copula. Okay, copula. So besides that, when you look at the same guy, the scala media, it is bounded by two membranes. So you have got a membrane on top. The membrane on top is known as the vestibular membrane, also known as the Reissner's membrane or vestibular membrane. And then when you come down, you have got the basilar membrane. So down here, you have got the basilar membrane. And then you have got now hair cells there, which have got a longer kinocilia and a shorter stereocilia. So specifically for the outer hair cells, there's going to be another membrane that is going to engulf them like that. You can see the hairs of the outer hair cells. There is an outer membrane that engulfs them like that. They are a bit inside, and that's known as the tectorial membrane. So on top here, the Reissner's membrane, which is also known as the vestibular membrane, is separating the scala media from the vestibular membrane on top. Sorry, from the scala vestibuli on top. The basement membrane is separating the scala media from the scala tympani down. So just that is what we need to understand. So now we can answer our question. Which of the following is true about the cochlear duct? Contains endolymph and is separated from the scala vestibuli by the Reissner's membrane. It contains have been mentioned. So please just pardon me on this one. The vestibuli is a membrane of the three spaces that I mentioned, like this. Vestibuli is on top, the tympani is down. Hope that's what I said. So this membrane that separates the media from the vestibuli is a Reissner's membrane. Okay. So it contains endolymph and is separated from the scala vestibuli by Reisner's membrane. It contains perilymph and separated from the scala tympani by the basal membrane. It contains endolymph and separated from the scala tympani by the tectorial membrane. It contains perilymph and separated from the scala vestibuli by the organ of Corti. Anyone that can help us with that question? Anyone? Now that, thank you so much. Please be free to open your mic and then be able to speak. Huh? So the answer is A. It contains the endolymph. Okay. Okay. So you have got these are three cavities. The way you can see them like this. Here you have got the scala vestibuli. Here you have got the scala tympani, scala media. So this membrane is a basilar membrane. The one on top is a Reissner, also known as the vestibular membrane. But you know, inside the scala media, you have got the organ of Corti, which contains the outer ear cells, the inner ear cells, and also the spiral ganglia. So just for the outer ear cells within the scala media, they are going to be bounded on top. Let's say this is your outer ear cell, specifically like that. You are going to have another membrane which will go like this. So it is covering the top part of the outer air cells. The inner air cells, the cilia is not covered by the tectorial membrane. So the tectorial membrane is part of the inside of the scala media, but not the actual one which is separating. So like you are going to have another membrane here just within. Hope you get that. Yes. All right. Which are the question 42? Which of the following is true about the hair cells in the organ of Corti? Now we've already, let me just draw them and then we answer this question. You can see these guys are like this. Now in the cochlea, you know the cochlea is involved in hearing. The cochlea has got inner and outer hair cells, so the one involved in hearing. At the bottom of the hair cells, specifically the inner hair cells, they are the ones that are involved in hearing. The outer hair cells, those guys are get information from the olivary nucleus, okay, from the olives. That information is coming from the central, from the brain. So the information coming from the brain is coming to the outer hair cells so that there is amplification, because what is happening is this. Remember, the hair cells rest on the basement membrane. Both the inner hair cells and the outer hair cells are found on the basement membrane like that. Actually, the outer hair cells are a lot. You are going to find them in a row of three like that. Inner hair cell is going to be alone, it's just in a row, only in one row like this. So the inner ear cells are the ones specifically involved in hearing. Why? Because when information has come from the outer ear, this is our outer ear, it passes through the external auditory canal, it hits on the eardrum, the information is transmitted to the malleus and then to the incus and then to the stapes. The stapes is connected at what we are calling the oval window. Information is going to now come. Those vibrations from the stapes is now going to be transmitted inside, because the fluid which is inside it can't compress the way water is. Water is incompressible. So when there is this vibration, it's going to push on these air cells. So that is going to cause this basal membrane where the air cells are resting to start vibrating. When the basal membrane starts vibrating, these air cells are connected by what we call tip links. Tip links. And these tip links contain potassium gated channels. Remember we said that the scala media has got more of potassium. because it has got the endolymph which has got high potassium. So these stippling, see what is going to happen is because of the vibration of the basal membrane, the shortest stereocilia is going to move towards the longest stereocilia, which we can as well call as a kinocilia. And when that happens, this channel is open and potassium starts to flow to the inside of the cell. When potassium flows to the inside of the cell, at the bottom, potassium will start leaving, calcium will start entering. When calcium enters, it's going to cause exocytosis of neurotransmitter, which is the excitatory neurotransmitter. And that is going to go on this neuron here. So that has caused the depolarizing potential on the neuron. These neurons are going to gather a lot of them from different air cells, specifically inner air cells, and they are going to go in what is known as a spiral ganglion, and then now is going to go to the auditory cortex. This is the inner ear cell, but the outer ear cell, what the outer ear cell does is that it is going to receive information from the brain through the olives in what is known as the olivocochlear bundle, because it's coming from the olives to the cochlea. And that information is basically to strengthen the vibration of the basal membrane so that there is amplification of sound. So that is a direct way in which the brain can actually regulate hearing, direct, through the outer ear cells. So which of the following is true about the hair cells in the organ of Corti? There are mechanoreceptors that depolarize when stereocilia bend towards the kinocilium. There are chemoreceptors that hyperpolarize when glutamate binds to their receptors. There are thermoreceptors that depolarize when the temperature of the endolymph increases. There are photoreceptors that hyperpolarize when light stimulates their rhodopsin. Anyone that can help us with this one? Hey, thank you so much. So that's the correct one. Okay. 43. Which of the following is true about the vestibular system? Now, let's just look at this so that we can answer our questions real quick. We have got these structures. We have got three semicircular canals, and at the end of the semicircular canals, there is a dilatation which we call the ampulla. And inside the ampulla, you have got what we call crista ampullaris. And the crista ampullaris is actually the point where you are going to have crista ampullaris. That's where you are going to specifically have those receptors that are going to be picking up rotational acceleration in the ampulla, the dilatation at the end of the semicircular canals, crista ampullaris. Connected to the semicircular canals, you have got the utricle. Connected to the utricle, you are going to have a circle. I can write it here, a circle. Now, inside the utricle and circle, these two guys, we call them otolith organs or the vestibule. The three semicircular canals, utricle, and circle, they are known as a vestibular apparatus. By the utricle and circle alone, they are known as a vestibule or the otolith organ. These two, the utricle and the otolith organs, will be picking up linear acceleration or gravitational pull. Now, the way you can think of this is that the utricle is arranged going upward. So they are like this. Because these guys are not involved in hearing, they're involved in balance. Instead of having out and inner air cells, they have got type 1 and type 2 air cells, which are similar to the out and inner, which are found in the cochlea. So you can see how the utricle is. Think of U. U is like this, it goes upwards. So these guys are oriented in this direction. They are oriented upwards. Those are the utricles. And then you have got the circle, which have got air cells like this. So what happens is that when you are standing upright, you are pushing against these air cells. And so the shortest ciliocida is going to be going towards the longest cilicia. And so for you to be able to notice that you are standing, the circles are responsible for that specifically. And then when you are lying down, what will happen is that orientation will change. The utricles are the ones that will be facing this direction. And then the circles will be straight. So you now start pushing against these guys because now you are lying. And so what will be picking up that you are lying down will be the utricles. So you can see these guys are picking up information when you are standing vertical, and then these guys will be picking up when you're horizontal. So of these guys that we have said, from the semicircular canals, these guys are going to you are going to have a branch of the nerve coming from the semicircular canals, and then also from the circle and the utricle. So this is going to form a ganglion. From the circle and the utricle, we are also going to have another ganglion like that. So these two are going to form what we call the vestibular ganglion, and then it's going to go to the vestibular nucleus in the third ventricle. So you can see you have got two vestibular ganglions, and then you have got one spiral ganglion that picks up auditory information, not balance. So in total in the ear we have got three ganglia. So which of the following is true about the vestibular system? It consists of three semicircular canals, two otolith organs, and one ampulla. It detects angular acceleration, linear acceleration, and head position. It sends signals to the cerebellum, spinal cord, and oculomotor nucleus. All of the above. Anyone that can help? D, thank you so much. It's all of the above. Remember the vestibular, the inner ear is related to the cerebellum for balance, also to the spinal cord so that you can be able to move your muscles in order to maintain balance. Oculomotor nucleus so that you can be able to fix your gaze on one thing to be able to maintain balance. Which of the following is true about the vestibulo-ocular reflex? It stabilizes the gaze during head movement by producing eye movement in the opposite direction. It involves the three neuron arc consisting of vestibular afferent, vestibular nucleus, and oculomotor neuron. It can be tested clinically by the caloric test of the head, impulse test, or of the above. Anyone that can help with this one? Anyone? Let's be let's be free to contribute. Thank you so much. It's also all of the above. Are we good with this one? We can move? Okay. Please, if there's something that you're not clear on, you can still go on and ask. Which of the following is true about Meniere's disease? This word. Okay, let me mention something about this disease. This is a disease that affects balance. So what happens in this disease is, you have got the cochlea, these are three semicircular canals, and then you have got your otolith organs and those. So these guys are connected to what is to to a duct here, and this duct is aimed at draining the extra endolymph. We call it the endolymphatic duct. At the end, we are going to have the endolymphatic sac, and then it is going to take the endolymph to the cerebrospinal fluid. That is how endolymph is drained. But then in this condition, what happens is that there is accumulation of endolymph, probably because there is a blockade of the endolymphatic sac or the endolymphatic duct. So there is no drainage. And some drugs that are used to treat bacterial infections, like streptomycin. Let me ask, what class of drug is streptomycin? Anyone? Okay, so this thank you so much. So amylo glyco amylo aminoglycoside. Specifically, we know, thank you so much. Specifically, we know that this guy is inhibiting 30S ribosomes. That's how it works. Okay, away from that. So streptomycin can actually lead to the destruction of the air cells besides just the endolymphatic duct being blocked. And the same accumulation of the of endolymph because of the blockade of the endolymphatic system can as well lead to the damage of the air cells. So what will happen is that there's going to be edema, and another cause that can result to the damage in this condition is edema of this space, okay, edema of the space that is surrounding the endolymph. So if there is edema, there's going to be compression on the air cells, and there's going to be damage on the air cells. So how are you going to treat this condition? Surgery can help. You can as well give diuretics and steroids. You want to someone to lose a lot of water so that it can reduce on the edema. Also, H1 antagonists as well can help. So that's how you treat this condition. So which of the following is true about Meniere's disease? It is caused by increased pressure in the endolymphatic sac due to impaired absorption of endolymph. It manifests as episodes of vertigo, tinnitus, hearing loss, and oral phones. It can be treated with diuretics, low salt diet, vestibular suppressants, or surgical depression, all of the above. D, thank you so much. So this is how they manifest when someone has got this disease. You feel like you are spinning, but then you are not really spinning, and then you are having rings, feeling ringing sensations in the ear, some hearing problems. Which of the following is true about the olfactory receptor? Olfactory. They are located in the olfactory epithelium in the roof of the nasal cavity. They are modified bipolar neurons that can regenerate. They express only one type of olfactory receptor protein out of about 1,000. All of the above. Anyone? It's also D. Thank you so much. Actually, the olfactory system is the one of those most special systems in that uh, the actual olfactory cells are not found in a ganglion. So just in the roof here is our cribriform plate. Down here we are going to have olfactory cells, which are bipolar cells, and then down here they have got this cilia. And then a lot of them are going to come together to form the olfactory nerve. Olfactory nerve is going to synapse on what we call the glomerulus with second order neurons. You have got different ones. You have got tufted cells and mitral cells. So those two types of cells, the tufted cells and the mitral cells, are excitatory. You also have what they call periglomerular cells here, which are inhibitory in nature because they produce GABA. You also have another type of cell, which I've forgotten the name, that also is inhibitory just here. And then the information is going. It's actually the only sensory modality that can go direct to the cerebral cortex minus passing through the thalamus. Which of the following is a mechanism of adaptation to prolonged odorant stimulus? Increased synthesis of cyclic adenosine monophosphate in the olfactory receptor cell, increased opening of sodium and calcium channels in the olfactory receptor cells, decreased release of neurotransmitter from the olfactory receptor cells, or of the above. Anyone that can help with this one? Anyone? So just like, let me just describe a bit and then we can come back and answer. Here is we'll start first with our neuron. Let's say this is a cribriform plate. You have got your first order neuron there. So this neuron, you can see at the end. Now we can make it much bigger so that we go at the molecular level to see what is really happening. So what happens is that to these neurons, you have got a G-coupled protein. So for that G-coupled protein, you know it is 7, passes 7 times here. You have got a receptor at the end. So the first thing is that your odorant should be able to dissolve, and then it will come and bind to this receptor, which is a GS coupled receptor. When that happens, there's going to be stimulation of the G coupled protein, the alpha sub, and that will lead to the displacement of the GDP that is present here, and then you are going to substitute GTP. The alpha subunit that has got the GTP is going to go and activate adenylate cyclase. When you activate, so that's the alpha subunit which has got GTP, is activating adenylate cyclase. When you activate adenylate cyclase, it's going to lead to the conversion of ATP to CAMP. What CAMP does is that it's going to go again on the membrane and open sodium gated channels. When it opens these sodium channels, sodium will start flowing to the inside of the cell. When sodium flows to the inside of the cell, what happens is that it leads to a depolarization that is going to lead to also the influx of calcium, and calcium is going to lead to the exocytosis of neurotransmitter. But what happens is that, if you wondered, if you step in a room that has got chicken, you first smell the chicken. Oh, this place is smelling nice. After you stay for long enough, you stop smelling the chicken, but the chicken is still there. Or have you wondered why you can't smell yourself? However much you try, you can try even right now. You will not smell yourself, because we are adapted to our own cells because we are near. So when you are near an odorant, you get adapted to the smell there because of excessive activation of this system. What happens that when sodium accumulates very much, is going to go, and the calcium will start going to close this channel, and so that leads to adaptation. So I hope we've gotten something. So which of the following is a mechanism of adaptation to prolonged odorant stimulation? Increased synthesis of cyclic adenosine monophosphate in the olfactory receptor cell, increased opening of sodium and calcium channels in the olfactory receptor cell, decreased release of neurotransmitter from the olfactory receptor cell, or the above. Anyone that can help? Anyone? So it's all of the above. So you can see adenylate cyclase is going to be a lot. That when it is a lot, it will activate more of the CMP. You are going to have more sodium and more calcium going in. At the end, those guys are going to start inhibiting the channel so that you don't release neurotransmitter. If there's no release of neurotransmitter, it will mean that there's not going to be generation of actin potential for you to be able to perceive the smell. Which of the following is true about the gustatory receptors? They are located in the taste buds of the tongue and other parts of the oral cavity. They are specialized epithelial cells that release neurotransmitter onto afferent nerve fibers. They can respond to more than one type of taste molecule. Anyone that can help with this one? D is also of the above. So here is the tongue. Let's talk about this. The back of the tongue. What type of what do you call it? Taste does it respond to? The back of the tongue. So the back is bitter. Thank you so much. Like you can just think of your medicine when you are trying to drink the medicine and then it's stuck. And then how about on the sides of the tongue? Which one is the majority on the sides of the tongue? Sour plus what? Even salty. And then the tip of the tongue, the tip is sweet. Yes, thank you so much. So the way these guys help in generating an action potential is that for let's start with something easy. The sour is related to hydrogen. It is also known as acidic. So what will happen is that the hydrogens are going to go and attach on the receptor. When they attach, they are going to close potassium channels. So potassium will not be able to leave the cell. If potassium is positive, if it doesn't leave the cell remains positive, and that's how an action potential is generated. And then when it comes to the salty works by what is known as the amyloride sodium channels. So what will be happening is that when you eat salty food, just think salt itself contains is actually the table salt we use is sodium chloride. So the sodium binds to the receptors, opening these channels, and then sodium starts to flow in, and that leads to the action potential. Sweet and bitter, they work by G proteins. Specifically for the sweet, it is working via GS. GSC, this is the adenylate cyclase. So what is happening is that your molecule of your food molecule attaches to the G coupled receptor. There is activation of adenylate cyclase. When that happens, it converts ATP to CAMP. CAMP, the end result is that CAMP is going to close potassium channels. When you close potassium channels, then that is going to lead to no potassium leaving. And how it does this is that when the CMP accumulates, there's going to be what is known as the activation of phosphokinase. Phosphokinase is the one that is going to come and phosphorylate these channels and then close them. For the beta, it works also via G protein, but specifically it is GQ. GQ, what happens that when your test guy binds to the receptor, there is activation of the G protein. When the G protein is activated, what is going to happen is that is going to lead to activation of phospholipase C that is going to break down PIP2 to IP3 inositol triphosphate and DAG, diacylglycerol. So those are the two guys that you are forming. Specifically, when you form IP3, IP3 is going to lead to an intracellular increase in calcium. And when that calcium increases inside the cell, there's going to be exocytosis of neurotransmitter. So this is how these guys work. So we've already answered this one. We've said it's D. Which of the following testants detected by a G protein? Which of the following testants is detected by a G protein coupled receptor mechanism? Sodium ions, hydrogen ions, sweet molecules, or of the above? Anyone? Which of this is detected by a G protein? Anyone, guys? Doc Sanga, would you want to say something? Doc, Blessing, Karen, John, anyone? All right. Please go on. Go- Thank you so much. It's a C. Remember the only two that are carried by G protein is sweet and sour, not sour and bitter. Which of the following cranial nerves carries taste information from the anterior two-thirds of the tongue? Facial nerve, glossopharyngeal nerve, vagus nerve, trigeminal nerve. The facial nerve. Thank you. How about the glossopharyngeal? Posterior one third. Thank you. How about the vagus? The oropharynx, or just the rest of the other taste receptors. Pharmacology now, neuropharmacology. The psychiatrist in the emergency department plans to initiate lithium while awaiting a bed on the psychiatric unit. Which of the following suggested predictors of lithium non-response? Remember non-response. If present, would make you recommend an alternative agent. If it's present, you are not going to use lithium. Instead, you use an alternative. A history of suicidal ide- ideation. B, the presence of mixed features. C, family history of lithium response. D, two episodes within a, a 1 year time period. Anyone? Anyone to help with this? Pardon? B? Which one am I getting? B or D? Anyone else? I didn't get that clearly. Oh, B. Okay. Anyone else? Do we all agree with B? Doc, why do you choose B? Would you love to explain? Okay, there is also A. Thank you so much. Would you want to explain, Doc? Okay, thank you. So, lithium. When lithium is being taken, it has got some side effect, and one of those side effects is that it leads to suicidal thoughts. So it's one of those things that you want to be able to look out for these suicidal thoughts. Okay. Now remember, here we have not yet started the drug. The question is which of the following suggested predictors of lithium non-response? If present, would you make or recommend an alternative? So the lithium is going to end up causing suicidal thoughts before you can even start giving it. Like you see someone having those suicidal thoughts. So don't want to give them again because it might just worsen that and they kill themselves. The patient is started on lithium and now undergoes an orthopedic consultation for ankle pain, which is improving. Ankle fracture is ruled out with an X-ray, and now the physician asks for a pharmacologic option for pain control. What medication plan would be the best recommendation? Remember, this patient is taking lithium. A, duloxetine 60 milligrams. B, tramadol 50 milligrams. C, naproxen 500 milligrams daily and such. D, acetaminophen 1000 milligrams. So which one would we pick? Someone is taking lithium and even they are having pain. So which one of these drugs would be the best to manage that pain? Especially that the ankle pain is improving. D, thank you so much. Any reason why you would go for that? Any? Okay. So when you look at these guys, what D is of course good, yes. Acetaminophen or naproxen. Why would you go for that, doc? Any reason? Okay. So that is what type of drug is naproxen? Thank you so much. So that's what I needed us to understand. So when you look at lithium, there are drugs that can increase the concentration of lithium. Specifically, those drugs that lead to dehydration, that will lead to loss of water. It will lead to toxicity. Specifically, NSAIDs, you don't give them together with lithium. And also, you don't give these diuretics like the loop diuretics and also the thiazides. Don't give these together. You know, the thiazide and the loop guys, someone is losing water, and so as they are losing that water, it means that the concentration of the drug is going to be increasing. There are also some drugs that reduce the concentration of lithium. Drugs like theophylline. Anyone who remembers the class of drug this guy is? Semethylxanthine. So you don't give this drug is going to reduce the concentration of your lithium. And also things like caffeine. Caffeine will also reduce the concentration of lithium. So these two guys. When you look at A is specifically, is it SSRI, selective serotonin reuptake inhibitor? So it is not used for pain. Tramadol is used for pain, but you know it has got some form of addiction, right? You want to avoid that because it's much strong. Naproxen is an NSAID, and these guys are supposed to be avoided. Acetaminophen is not an NSAID. It can be classified in that category, but it works on a different enzyme. So it has no really effect on lithium. Yes, Doc? Hope that is okay. Baseline laboratory screening before starting valproate. Yes, please. They So if you want it to be effective and these drugs are reducing the concentration, it means that it will not be effective. So we just want to take note of that interaction. So if let's say for example you are thinking of giving, let's say, 60 milligrams per day or something like that, should be aware that if we give this, the concentration of lithium is going to reduce. Yes. Right. Baseline laboratory screening before starting valproate should include which of the following: ammonia, liver function tests, HLA-B 1502 variant, thyroid function tests. Anyone to help? A, ammonia. Okay, thank you so much. Anyone also? Liver function tests. Anyone else who have got these two? Anyone else with another thought? We need the third party. What the third party decides will give us what we are picking. Anyone? Okay. So one thing we need to take note of with the mood stabilizers is that for lithium you really want to pay attention to the kidney because it affects how the drug is going to be able to work because of toxicity and such. And then for valproic acid, you really want to pay attention to the liver because it really affects how the drug is going to be able to work. Actually, you don't give this drug when there is liver damage. So you really pay attention to the liver when it comes to this drug. So when you hear lithium, kidney, valproate, the liver. So we want to do some liver function test to make sure that the liver is okay. That should be because the drug is removed in the liver. A 34-year-old woman with bipolar disorder has been controlled on lithium 600 milligrams 2 times daily for the past 18 months after failing other medication trials. She presents to her primary care physician for increased nausea and vomiting, which are the like the early signs of lithium toxicity. Lithium concentration is 1.1 and she is found to be approximately 4 weeks pregnant. Her past psychiatric history is complicated with 6 complications since the age of 18 for both manic and depressive episodes, all severe with mixed features. She has attempted suicide 3 times. What is the best course of action in this patient? Begin a slow cross tapper to dalvoproxisodium, discontinue lithium, and begin a clozapine titration. Start a slow tapper of lithium to a target concentration of zero point 0.6. Stop the lithium and avoid the use of psychotropic medications. Anyone that can help us with this one? Anyone? Pardon? B. Why would you go for B, doc? Discontinue lithium and begin a clozapine titration. Of course, let me just mention something in case someone is wondering. You can use second generation antipsychotics to treat mania or manic episodes or bipolar. When you're talking about bipolar, it is like so. You're having going up, this is mania, like where someone is very happy, and then going down, this is someone is sad. So at points they are happy, at points they are sad, just like that. So specifically, mood stabilizers are aimed at treating mania. Someone presents, they are too happy, they are talking too much, they have got euphoria. That's when you can be thinking of giving them lithium, valproate, and these other drugs. So, and also second gen. So there is B and C. Would you want to explain C, Doc? Thank you so much. Okay, so that's actually the best one. The mark you want to go to a concentration of up to zero point 0.6 because that will be before toxicity. When you start going beyond zero point 0.6, that's when the toxicity effects of lithium starts to appear. So I want to start small and then you start increasing the concentration not until you reach zero point 0.6, which is should be the maximum. So that is going to reduce the exposure. Remember, this woman is pregnant, so it will reduce the exposure of the fetus because the drug is not having a bigger concentration. Plus, the patient will be at least better. So you discontinuing the dose might just cause relapse where the symptoms come back. And clozapine is really not too good because, of course, we can think of changing to another drug, but clozapine is not even the best. It has got a lot of side effects like agranulocytosis, seizures, even gestational diabetes. So those are the things that we want to think of. And just discontinuing the drugs will not be the best option because this woman is, having a problem here. And then the other drug for a divarproxysodium should be avoided in pregnancy because of neurotube defects and low IQ for the baby that can be born. So the best is C. A 26-year-old patient is being discharged today after being hospitalized for treatment of manic episode associated with bipolar disorder. The patient is being discharged on lithium, olanzapine, lorazepam with an outpatient clinic follow-up in 2 weeks. The patient expresses a new interest in having a health lifestyle to include a regimen of dieting and exercise. What would be the most important education point related to the medication safety over the next 2 weeks to provide? Remember, this patient has got bipolar. Actually, specifically, you want to be treating the manic phase of the bipolar. You are discharging them on lithium and these other, specifically lithium, it can go into toxicity. And they want to have a healthy lifestyle, like dieting and exercising. So I want to give them advice. A, describe the risk of exercise, excessive caffeine intake that may result in elevated lithium concentration. Caution to not abruptly reduce or fully eliminate sodium from the diet because this may result in decreased lithium concentration. Describe the signs or symptoms of lithium toxicity and the importance of adequate hydration during exercise, as overexertion with dehydration may result in increased lithium. Support the decision to take on a healthy lifestyle and advise that the metabolic effects of olanzapine may contribute to cardiovascular disease. So the doc picks C. Anyone else? Thank you so much. So basically that when you look at A, decrease the risk of excessive caffeine intake that may result in elevated lithium. What is the effect of caffeine on lithium? Does it elevate or decrease? It decreases. So already this option is lying. And then be caution to not abruptly reduce or fully eliminate sodium from the diet because this may result in decreased lithium. So eliminating sodium from the diet You can think it properly together with dehydration. When someone is dehydrated, there is increased lithium instead of decreased. So when you don't have enough sodium, like the reduction in sodium, just like reduction in water, which is basically dehydration, those are going to result in toxicity. You know, when you lose sodium, sodium is normally lost together with water. So you can think of it in that way. That increases this toxicity for this guy, not decreases. And then for C, this person wants to start taking up exercise. And when someone is exercising, you know, they are sweating, they are losing both water and sodium. So meaning that they're going to be toxicity. So I want to tell them to be taking a lot of fluid so that they can be able to help themselves not to go into toxicity. 56. According to the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders, which is not a core feature of dementia with Lewy bodies, impaired cognition with changes in attention and alertness, visual hallucinations, persecute spontaneous motor features similar to Parkinson's disease, persecutory delusions. Anyone to help with this one? Anyone? All right. So when we are talking about dementia, we know dementia. Please take note of this. It's high yield. Dementia is a development of multiple cognitive defects. Please don't forget the word multiple. She really emphasized this. It can come maybe in a multiple choice, just a development of cognitive deficits. Dementia is characterized by development of multiple cognitive deficits, like someone has got memory impairments, there's aphasia, they can't inability to find pleasure in things, to initiate complex behavior, so all those problems. And you have got different types of dementia, the most common being Alzheimer's disease. And then you also have what they call vascular dementia. And the vascular dementia is specifically associated with people that have got like high blood pressure, diabetes, also high cholesterol. So what is happening is that blood is being disturbed from reaching to the brain and is affecting memory there. Another is known as nutritional dementia. That includes nutrients like vitamin B3 and vitamin B12. You know, if someone lacks B3, which is niacin, there are four Ds like dermatitis, dementia, death. So dementia is part of them. There is also another dementia which is associated to HIV. So HIV associated dementia, specifically not any type of HIV, but HIV one. So when you're treating this one, you're basically giving ART, antiretroviral therapy. You also have Lewy body dementia, and here you are basically having an accumulation of two proteins, alpha-synuclein or ubiquitin. So specifically for this guy, it has got what they call core symptoms. The symptoms are to for Lewy body dementia. Now remember, in Parkinson's disease, there is also the accumulation of these Lewy bodies. So in Lewy body dementia, the core symptoms are three. There's going to be some fluctuating cognition, like someone appears fine, you know, when it comes to the brain, normally thinking, analyzing things, is fluctuating. They appear good, not good, good, not good. They can think properly later on, no. There's also visual hallucinations. No, I'm seeing my wife that died 50 years ago. And then there's also some symptoms that are similar to Parkinson's disease because of the same Lewy bodies. So these are the three core symptoms. There's also another type of dementia which is known as frontotemporal dementia. So those are the main ones. Okay. And how you treat these dementias, because they are you are basically affecting, you are destroying these neurons. All these different things can destroy the neurons, like the Lewy bodies in the central nervous system, decreasing your neurons there. Your as sorry, you are decreasing your neurotransmitters. So the treatment is aimed at basically increasing these neurotransmitters. For example, you can give acetylcholine stress inhibitors so that you don't break acetylcholine. And acetylcholine stress inhibitors, you have got donizepam, you have got rivastigmine, you have got galantamine, and then you have got tacrine. These are the main four guys that you give the acetylcholine stress inhibitors. But you normally don't use tacrine because it shows hepatotoxicity. It's like this, tacrine. But donizepam, rivastigmine, and galantamine, you can give them. They've got like similar effects. Besides that, you can also use NMD blockers, those drugs that will be able to block your glutamate. And you have got one important drug there, which is known as a mamantine. Some side effects that, so if you are giving these guys on top, which are acetylcholine stress inhibitors, so just think of what does acetylcholine do, the side effects of acetylcholine. You know, acetylcholine is produced by the parasympathetic. Parasympathetic is you are resting and digesting, so you want to go to the toilet and all those things. You can think of the effect of acetylcholine, right? And you are really seated, your pupil is small, and all the others. And then for NMD receptor antagonists or blockers like memantine, to lead to things like dizziness, headache, and confusion. Those are the main ones. And for this guy, how it works is that it's going to slow intracellular calcium accumulation, because calcium is not accumulating in the cell. That will prevent the damage of the neurons further, because in these conditions, in dementia, there's damage to the neurons because of the calcium. And so it also slows the rate of cognitive function. Okay, the way someone is losing the cognitive function. You can also give antipsychotics for those whose behavior has already changed, because this guy affects memory, because people end up having aggressive behavior. So you can also give antipsychotics. You can also give antidepressants, but don't give antidepressants like TCAs. You know, TCAs have got different effects on different receptors. So I want to avoid those antidepressants that have got effect especially on the acetylcholine, because acetylcholine is needed for cognition in the brain. And the problem here is that they lack cognition. So if you give those which are again blocking acetylcholine, it will worsen the symptoms. So the best antidepressants you can use are the selective serotonin reuptake inhibitors, SSRIs. And then you also want to avoid giving sedatives like the benzodiazepines, because those produce inhibitory neurotransmitters that will still be reducing your neurotransmitters, and so they will worsen cognitive impairment. So basically that is it. Okay, so we can now answer our question here. According to the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders, which is not a core feature of dementia with Lewy bodies. Impaired cognition with changes in attention and alertness, visual hallucination, spontaneous motor feature, persecutory delusions. D, thank you so much. So we refer to this statement here for the next four questions, which are the last four. An 85-year-old female patient reported to the geriatric clinic with family concerns of gradual memory loss, The family reports gradual decline in cognitive function, medical history of significant medical history is significant for diabetes mellitus and hypertension. You can think of vascular dementia, right? She has some difficulty walking and balancing due to prior accident many years ago. Current medications include glipizide twice daily, 5 milligrams twice daily, aspirin 81 milligrams daily, lisinopril 10 milligrams daily, and atorvastatin, which is a statin given at bedtime. Current blood pressure is 143 out of 87 millimeters of mercury. All laboratories are within normal limits, with the exception of her serum creatinine and the creatinine clearance. Her current mini mental state exam is 21. After further testing and follow up, she is diagnosed with probable Alzheimer's disease. The psychiatric wants to initiate the patient on an acetylcholine esterase inhibitor. Which agent would be most appropriate to recommend? Donepezil, galantamine, memantine, rivastigmine. So here you can see when it comes to the clearance, creatine clearance, 17. That's very low. So it means that there is some kind of problem on the kidney. And this guy is not excreted there. So it's going to be better because it will not lead to those toxicity things. Memantine is not even an acetylcholine esterase inhibitor, it's actually an NMDA antagonist. Following the initiation of an acetylcholine esterase inhibitor, which is the most appropriate fact to educate the patient and caregiver. Stop, the drug is going to stop further memory loss, it is going to slow the progression of the disease, worsen agitation and aggression, restore memory loss permanently. Anyone? Which one of these are you going to tell the? Thank you so much. So when it comes to the brain, these things act, you don't heal them. You don't stop further loss. You just slow the rate at which you are losing, and you never restore permanently the memory. Once it starts, it starts. Which are common side effects associated with acetylcholine esterase inhibitors? The common side effects: GIT distress, insomnia and weight loss, blood, blood clots, weight gain, sedation, GIT distress, suggestion and extrapyramidal symptoms, weight gain, insomnia, and tachycardia. Anyone to help with this one? Anyone? Okay, so the side effects: GIT distress, yes, weight loss, and insomnia. These are common for these drugs. A. GIT distress, like problems on the GIT. Remember, acetylcholine, parasympathetic. When someone is just sitting, they want to go to the toilet, so there's diarrhea. They want to urinate, so there's urinary incontinence and all those other things. There's also weight loss and insomnia. Eh, After 2 months, the family brings the patient to the urgent care emergency room with a notable decrease in cognitive function. The patient is diagnosed with delirium. Psychiatrist contacts you for recommendation to treat delirium. Which agent would be the most appropriate based on request? Aripiprazole, clozapine, IV haloperidol, or oral haloperidol? So which antipsychotic would be the best to use? Someone that has got delirium. Anyone? Okay, so the best air that you'd want to use is aripiprazole. We know the problems that come with clozapine, it being one thing that it causes that is very, very common. Anyone to mention it? The most common side effect of clozapine. Yes, you are going to have those granulocytosis. Haloperidol is a first generation antipsychotic, and you know why we normally don't recommend first generation antipsychotics? These guys, they show extrapyramidal side effects, so aripiprazole ends up being the best. Which medication listed above is the most appropriate choice? Opioids are drugs that you are going to use more especially for pain relief, right? The badness when it comes to opioid use is they have got some side effects like sedation. They depress the central nervous system. Besides that, they can as well depress the respiratory system, and they also suppress cough. So meaning that someone that is taking these drugs will not be able to cough because of suppression. They also cause meiosis. The pupil becomes small, except one. And then they also cause nausea and vomiting, GIT symptoms. They will be able to relieve diarrhea because they act direct on the intestine. So the opposite is going to be true, right? They can cause biliary tract spasm, the contraction of the biliary tract, because they are going to work on the sphincter of OD to close it, meaning that they can affect the digestion of lipids. And this effect can be reversed by naloxone. And then they've also other side effects like itching. So when you look at, let's start with where, okay, I'll just mention them. Morphine is a prototype for these opioids. It can be given IM, IV, subcutaneous, and those. It's broken down in the liver. But the guy is not well good because of addiction. Dimorphine, which is heroin, is even more potent than morphine. No any medical use except that it is known for abuse because it causes euphoria. You also have pethidine. Pethidine is also known as, is that a question or something? Okay. So pethidine is also known as meperidine. This guy is also known as dimero. It's less potent than morphine and it causes less respiratory depression, as we said, for other analgesics. And another good thing about pethidine is that it has got no effect on the cough reflex. So meaning if you give it, no, someone won't be disturbed when it comes to coughing. But it can cause tremors, muscle twitches, and convulsions rarely. It's metabolite, yes, it's mydriasis because the others will cause meiosis. It's the only one. Another problem it has is that it is going to cause tachycardia. So just one thing that we need to take note also that was emphasized is that it has got a shorter duration of action and has got a fast onset of action. It causes less depression in the newborns because there are some enzymes that the newborns don't have, like those that are going to be able to break down the drug. So it is going to be preferred in biliary ureteric, in those conditions where the biliary system is already contracting, because remember we said that the problem here is there's going to be biliary tract contraction. So this one is preferred because it doesn't cause that. And then it is also good to be used in the pregnant because it has got less effects there. Methadone, where is the guy? This guy here is given normally. It has got equal action like morphine, but lead to addiction. So it is given for those that have got opioid dependency. It is going to be substituted so that they can be treated for opioid dependence. There is this one that is associated with deaths, especially most deaths in the United States, fentanyl. It is more lipid soluble than morphine and it's more potent. It's used as a general anesthesia. Even in small doses, it is deadly and it is one of the major causes of deaths because of overdose worldwide. We also have codeine. Codeine is less potent than morphine and it produces less euphoria. It is a good antitussive for those that can't cough, that have got too much coughing, you can give them. But it does not cause analgesia. It doesn't stop pain. And it has got lower abuse potential than morphine. So you use it for mild to moderate pain and also to suppress cough. It is a good antitussive. We also have other guys like this first one here, buprenorphine, which is having a high efficacy. It is also an antagonizer or an antagonist to morphine. So in case someone is abusing morphine, this one is an antagonist. Tramadol is going to be used for moderate to severe pain, binds on new receptors. It can cross the placenta and enter breast milk, so you can see the effect of tramadol. And it is metabolized by the cytochrome enzyme. What else should you know about that? And then you have got antidotes. So remember we mentioned methadone. Methadone is used for dependence, but the antidotes is naltrexone and naloxone. J there. Those two guys are used as antidotes to opioid dependence. So if someone is dependent, let's say, yes, please. Methadone. Oh, methadone is used in opioid dependency. Like you substitute it for those who are abusing opioids, and then you'll be able to treat the dependency. And then naltrexone and naloxone, they are used as antidotes. Like someone has taken poison, what are you going to give so that you reduce the effects of the poison? So that will be naltrexone and naloxone for acting as antidotes, because they are going to reverse they act like psychomimetics. They are going to reverse the effects of the opioids. So, like the depression of the cardiovascular system, the respiratory system, these guys can be able to reverse those. So, I think that is what we can revise a bit on these opioids. We know this is a benzodiazepine. This guy, this is an SSRI. This is a benzodiazepine. So we can go now to our to our questions. You also have thiamine there. So James, okay, let's go back to what the doc asked. The drug that you, which drug causes this euphoria? Is it the same pethidine instead of euphoria? Anyone that can remember that? Okay, we are going to get it on the way. So we can go to, so James is in alcohol withdrawal, requires detoxification, however, significant liver damage. So which drug can we give for that? Of the drugs above. Thiamine, naltrexone, methylphenidine, methadone, lorazepam, fluoxetine, and the others. For someone that is in alcohol withdrawal but requires detoxification but has got significant liver damage. Thank you so much, Doc. So that is the lorazepam. Remember from the lecture on this alcohol withdrawal, you can use the benzodiazepines. Example there is the lorazepam that we can use for alcohol withdrawal. Mumba seeks medication to support abstinence from alcohol. She requires regular opioid analgesia for pain relief. Okay, so we are saying we can use disulfiram there. Okay, there is also part four that is also what before we can answer three. Vuadia is ambivalent about addressing his alcohol dependency. He lives alone and spends most of his day drinking. So what can we use now for this condition if we for the and then we also have this one. Hmm. Part 6, if we put thiamine there, is a cofactor in a glucose metabolism and the key in the management of alcohol withdrawal. Then what are we going to put here? Also, okay, okay. And then 3, Mary seeks treatment for opioid dependency. There is a family history of sudden cardiac events and she has a prolonged QT interval. Someone seeks treatment for opioid dependency and there is a family history of cardiac events. So remember we said that the same bupro something something there is also acting as an antagonist for the morphine. And then 5, used as first line in the treatment of attention deficit hyperactive disorder in children. Which one? So this patient is not concentrating. So we want a stimulant of the central nervous system. Like we have got hyperactive attention deficit. So this guy is a stimulant of the central nervous system. Has anyone a different option? Anyone with a different option from methylphenidate? Taking the drug for more than 3. Anyone? Okay, so we can pick this guy here, diazepam. So benzodiazepines, as we saw from our codependence and these other topics like and anxiolytics, you use them for 2 weeks. After that, they can cause dependence. Mulenga has been prescribed paroxetine to treat newly diagnosed generalized anxiety disorder. In the first 2 weeks, he experiences an increase and severity in anxiety symptoms. Which adjuvant drug would he require? He's taking drug for anxiety disorder, and you want an adjuvant, what you can add on top for anxiety. So which one of these can you add on top of anxiety? And when you look at this again, this statement, this is a newly diagnosed condition, and then you've given this patient, this is an SSRI. You know these guys take long. So in the first 2 weeks, he experiences an increase and severity in anxiety because that's how the SSRIs behave. Initially, they are going to worsen the condition and then later on they can help. So in that period when they are worsening, you want to give a benzodiazepine because it acts faster. So that's why we can use a benzo there like lorazepam. Is used in alcohol use disorder patients. Which one can we use in alcohol use disorder patients? Alcohol use disorder patients. So we can get this one, the antidote to opioids. Different answer for the alcohol use disorder patients. So when you give naltrexone, it is going to support abstinence in alcohol use disorder. And then the last one, well tolerated tricyclic antidepressants in the treatment of unipolar disorder. So you can see this guy, fluoxetine. This is should be an SSR. These guys are better than tricyclic antidepressants. You know these guys have got a lot of side effects. So we can get E there. Just here, cofactor and glucose metabolism, we picked K, which is thymine. Thymine is important every time, especially when you are giving someone that has got is trying to withdraw from alcohol and then they've got hypoglycemia. First, always give them thymine because we want to prevent Wernicke's encephalopathy. Actually, never give someone that has got hypoglycemia glucose without giving them thymine. Clearly, we want to label the diagram here. A. What is A? Anyone? The anterior lobe of the cerebellum. You can just hear that if you just write anterior lobe, it's wrong. So the anatomy, guys, I don't know, of the cerebellum. And then B, the outer part here. What is the outer part of the cortex? Of the cerebellum. Pardon? And then what can be C? Yes. So the arbor vitae is actually the medulla, which is the inside that is making the tree there. Arbor vitae. So this outer part is the cortex, cerebellar cortex, cortex of cerebellum. And then how about D? Posterior lobe, thank you. And then E, so specifically we know this is the third ventricle, right? The third ventricle, the fourth ventricle, because the third is supposed to be in the diencephalon on top. And they are pointing at these two structures that make cerebrospinal fluid. So the choroid of the fourth ventricle. And then how about F? Okay, florculonodular. So it's called like that because it has got two parts. It's like this. It has got the flocculus and the nodulus, flocculonodular lobe. And then how about G? A medulla oblongata. And then how about H? Thank you. What's the other name for the inferior cerebellar peduncle? Anyone? The rest from board. Those are my ways they'll be using if you've checked through their past papers. Instead of just saying inferior cerebellar peduncle, they've given a multiple choice. You know the answer that is inferior cerebellar peduncle, but then it's not there. So rest from board. And then how about I? The middle cerebellar peduncle. Thank you. What's the other name for the middle cerebellar peduncle? Pardon? The brachium pontis. Thank you so much. It has attached to the pons, so brachium pontis. And then how about J? What is this part? Superior cerebellar peduncle. What's the other name? Yes. So we start with the vertebral arteries. Let me write it like so. Here and here. So this one, vertebral artery. And then these guys are going on top to form a structure there. And that's where this system is ending, isn't it? And then we have got another part there where we are having parts like this connecting at the back. Of course, it's supposed to be going like that. And then we have got structures coming from here, and then like that, and then like that. Actually, from this same guy, we have got another part going like that, and then we have got parts here, and then we have got these guys here, then we have got these guys here, And then we have got here, from this guy, we have got also a guy that comes out of it there. And then we have got these nice ones here. Okay, so we can put them like this. What is this one? This one? Thank you so much. Posterior inferior cerebellar artery. And then how about, sorry, how about this one? The anterior spinal artery. And then we can come to this one. Who is this one? The ICA, anterior inferior cerebellar artery. And then who is this one? Labyrinthine, which is going to the inner ear. Labyrinthine artery. And then how about these short guys here? The pontine arteries, thank you. And then this guy here, the basilar artery. And then we can come to this one here, the superior cerebellar artery. And then this one here, the posterior cerebral artery. And then this one here, the posterior communicating artery. Please differentiate. This is posterior communicating, this is posterior cerebral. And then this one here, anterior cerebral artery. And then this one here, anterior communicating artery. This is communicating, this is cerebral. Also differentiate them, cerebral communicating. And then we have got this one here, the middle cerebral artery. And then we have got this guy here, internal carotid. And then we can now do our last one, which is this one, the ophthalmic artery. So those are the guys. The last one is just a quick one. Each part is just five marks, so it's not too much data I need to produce. Outline the parts and functional roles of the motor. Remember, motor cortex. The parts and functional roles of the motor cortex. Let's start. Which one is the first part of the motor cortex that we can mention? The yes, number one, primary motor cortex. That is area what? Thank you so much. Broadman area for where is it located? The precentral gyrus. Of which lobe? Of the frontal lobe. Thank you. And then what is the function? Because we just want to mention like the part and the functional role. What is the function of this guy? It controls voluntary movements, isn't it? And then the second area, which is motor, the premotor. That is area what? Area 6. Thank you so much. What's the location of the premotor cortex? Location is actually in the front of the premotor cortex, just in the front. This is area. Remember, this is our brain like this. Hope it's ish. Here is our central sulcus. In front here I've got the premotor cortex. Just in front to it, you have got the premotor. What is the function of the premotor area? So this guy is the one that programs the skilled motor activity. Skilled programs skilled motor activity, and they need to be able to direct the primary motor area to be able to execute. So skilled motor activity, anyone that can give us an example of a skilled motor activity? Thank you so much. Riding a bicycle, fighting, writing, typing. And then number three, any other motor area? Supplementary motor area. And this is area what? It's part of area 6. And what is the function? Where is it located? Let's start with the location. So for this one, the location is found on the middle aspect of the hemisphere in front of the paracentral lobe. And the function, anyone? Anyone? Okay. So this guy is also involved in planning motor movements. And then any other area? Any other? Broca's area, is it motor or sensory? So you can also mention Broca's area. This is area what? Area of motor planning, when to plan and also to prepare for movements, like complex movements. Actually, imagine you are moving, you see a box, they tell you that that box contains a lot of heavy things. And then you go there, you are trying to lift with all your strength, you lift it, you just found out there was nothing. So you are protected like that because the cerebellum and the cerebrum are also going to help in error correction to adjust to movements based on the feedback. So expecting something else and then you went there found something else. So you have to adjust to that, and this is also helping. And then Broca's area, where is it located? Which lobe? The frontal lobe. Specifically, when it comes to the frontal lobe, you have got the inferior, the middle, and the superior. Thank you. So the inferior frontal gyrus. And what's the function? Yes, for speech, for me to be able to speak. That's why Broca's aphasia, you can understand, but you can't speak. Wernicke's aphasia, you can speak, but you can't understand. And then for the last one we can mention is the frontal eye field. So you have got also this area, like area 8, that is involved in moving the eyes. When you turn to the left, the eyes can face the opposite direction. Outline and describe the extrapyramidal pathways of the motor system. Anyone that can say something about that? Extrapyramidal, just anything. Anything that you can say. Yes, please. All right. Thank you. So these neurons are coming from, the pyramidal system comes from the cerebrum and it is passing through the pyramids in the medulla and going to the rest of the body. But the extrapyramidal starts from the brainstem. We are going to have those that are starting from the red nucleus. We call them the rubrospinal. We're having those which are starting from the vestibular nucleus. We call them vestibulospinal. Those which are starting in the tegmentum of the midbrain, tecto, like in the tectum, sorry, so tectospinal. Those starting in the olives, you have got olivos spinal. These guys just coming from the brainstem going to the spinal cord. Like the rubrospinal, when it comes from the red nucleus in the tegmentum, that's the midbrain, it's going to decussate just there and then to the opposite side. The vestibulospinal comes from, the vestibular nucleus is found in the third ventricle, and the third ventricle is between like the pons, the medulla, and also the cerebellum. So it will come from there and then it will be able to go to the ipsilateral side. Okay, that's the vestibulospinal, and you are trying to control just the axial muscles and posterior muscles so that you can be able to maintain balance. The reticulospinal, you have got the pontine reticular formation and the medullary reticular formation. They form the lateral reticulospinal tract and the medial reticulospinal tract. The lateral is going to increase muscle tone. That's a work which comes from the pons. The lateral comes from the pons, from the pontine medullary reticular formation, from the pontine reticular formation to increase muscle tone. While the medullary, which is the medial, just think medullary medial, we will form the medial reticular tract, okay, and that is going to decrease muscle tone. Now, the way these guys are oriented is that let's say here is the place where I've got, remember we're talking about the reticular spine. The pons are a bit on top, the medulla is down. You have got the reticular formation in the medulla and the reticular formation in the pons. The ones in the pons are more medial, the reticular formation, and then the medulla is more lateral. But the same guys which are medial, these guys in the pons, they are going to form the lateral reticulospinal tract, but they are more medial in location. But the tract they form is lateral. And then these guys which are lateral, which in the medulla, they are going to form a medial pathway, but they are lateral in position. The medial pathway will be decreasing muscle tone. The lateral pathway from the pons will be increasing muscle tone. And then the tectospinal comes from the superior colliculus, and superior colliculus is related to vision, and the inferior colliculus, which is related to hearing. So these will basically respond to moving of our body or our head because of visual and auditory stimulus. You hear a sound, you turn. That's the tectospinal. And then the olivospinal comes from the inferior olivary nucleus, which is in the medulla, and then it will only end in the cervical region of the spinal cord and basically to move the neck muscles. And that is it for this one. Thank you so much.